Hello and welcome everyone. Thank you for joining us for today's special webinar in recognition of World Day Against Trafficking in Persons. July 30th is a United Nations recognized day dedicated to raising awareness and bringing global attention to the widespread and often hidden nature of human trafficking while promoting the rights and protection of those affected by it. My name is Ter Brkanovic and I'm the Education Supervisor at ACT Alberta, which stands for the Action Coalition on Human Trafficking. I'll be your facilitator for the next hour alongside my colleague Janice, who will be helping out in the chat if there are any issues. We're excited to be joined today by the UNED research team, who will be presenting the results of their findings. UNED stands for the Unit of Evidence and Deliberation for Decision Making, hosted by the Faculty of Medicine at the University of Antioquia in Colombia. UNED is composed of a multidisciplinary team with backgrounds in public health, epidemiology, clinical medicine, political science, and evidence synthesis. The team includes researchers and knowledge translation specialists working to improve decision-making processes, frequently in the health sector, through the integration of scientific evidence into policy and practice. Today, we will explore important new research and reflections from the UNED team and citizen partners on identifying and supporting victims of human trafficking in healthcare settings. Here is a quick look at the agenda for today or over the next hour. We'll start with a 15-minute presentation from Dr. Ivan Flores and Dr. Danielle Philippe Petitno-Lugo, who will provide an overview of the main findings from the scoping review. Then we'll be joined by two citizen partners, Esther Ekpe Adewuyi and Andrea Burkhart, who will share their reflections. This will be followed by a question and answer session where the team will answer any questions you have in the chat, as well as questions that were submitted earlier ahead of the webinar. And then we'll conclude and wrap up the presentation and session here by 1 p.m. So let's start off with the presentation of research findings here. I'd like to welcome Dr. Ivan Flores and Dr. Danielle Philippe Petitno-Lugo to share their screen. Ivan is a pediatrician, professor, and international leader in evidence synthesis, and Danielle is a health policy expert and co-founder of the Unit of Evidence and Deliberation for Decision Making. Together, they'll walk us through the key findings of the scoping review on tools for identifying victims of human trafficking in healthcare settings. So I'd like to welcome you both. If you can please share your screen now.
Hello, everyone. Good afternoon to everyone. Thank you for being here. Thank you for joining us for this event. Thank you to ACT Alberta for putting this webinar together. My name is Daniel Patiño. I'm a professor at the Faculty of Medicine at the University of Antioquia in Medellin, Colombia. And together with Ivan and with Marcela, we coordinate the Unit for Evidence and Deliberation for Decision Making, where our purpose is to inform decisions of different actors, physicians, citizens, and policymakers with the best available research evidence. And this, what we are going to present today, is one of those examples of how we do that. And the main strategy that we use is to synthesize research evidence in different products, like the one that we are going to present today. So today, Ivan and I will present the methodology and the results of a project that we conducted on behalf of the Sport Evidence Alliance that had as an objective to identify the tools and strategies to address human trafficking detection in healthcare settings. So can you move to the next slide, Ivan? So the objectives of these presentations are to present the methodology that we use to conduct this scoping review, to share the key findings from the review regarding the tools and strategies for identifying human trafficking, highlight the key messages, and summarize the main conclusions. Next. To do that, so after we clarify the research questions with our citizens partners, we follow the JBI approach, the JBI guidelines to conduct scoping reviews. We wrote a protocol and we registered the protocol in a platform that is called Open Science Framework. So everyone can go to that platform and read the protocol. We conducted systematic searches one in August 2024, and the other one at the beginning of this year, in different databases like PubMed, Embase, Lilacs, and different institutional repositories, where we look for different studies, individual studies, systematic reviews, guidelines, and different reports on tools and strategies for human trafficking detection in healthcare. After we identify these studies, two of our reviewers at the unit extracted the information following pre-specific extraction sheets. And finally, we summarize the results in a narrative synthesis using the UN framework and the epoch taxonomy that we can show you later. Something that is very important in this process is that two citizens partners that are here with us today, Esther and Andrea, were part of the whole process from the research question to the writing the results of this synthesis. Next. So just to tell you a little bit about the Sport Evidence Alliance, that means a strategy for patient-oriented research evidence alliance, which is funded by the Canadian Institute of Health Research. And it's a very interesting idea where decision makers and citizens and or patients can propose questions that can be answered to knowledge synthesis, like the scoping review that we are presented here today. So after citizens or decision makers put a question on the website, the sport team prioritizes those questions and then finds a team around the world or within Canada, a research team that can conduct the evidence synthesis. So we at the unit are one of those groups that develop evidence synthesis for sport, and we have engaged in other projects in the past. So the important part is that the citizens or decision makers, once they pose the question, they work with the research team throughout the whole steps to conduct the evidence synthesis. Some topics that are being conducted at this time by sport include strategies to increase equity in vaccination programs, approaches to prevent problematic opioid use, and interdisciplinary care models in mental health. Next. So this is the team that was engaged in producing this evidence synthesis, this scoping review. So as I mentioned, our citizens partner, Esther and Andrea, who were part of the whole process. And on the side of the research team by the unit, Marcela and my colleague Ivan, we coordinate the unit. Pamela is our senior researcher who is in charge of most of the projects. And then we have researchers such as Sylvia and David, who were in charge of most of the technical part of the report. Paola, who is our librarian, she was in charge of the search strategy and finding the documents to do this scoping review, and Lorena, who is our undergrad trainee.
Hello. Hello.
Next, Ivan. So now I leave Ivan, who is going to tell us a little bit about the results that we found in this scoping review.
Thank you, Daniel. So as part of the usual approach that we follow for scoping reviews, we do a full systematic search, as just Daniel explained. We go through different databases and also additional resources that he explained. And this is what we call the Prisma flow chart, in which we summarize the steps that we follow from the searches until getting the final paper that are going to be included. I'm not going to detail all the specific boxes here, just to highlight here that from the initial screening, we have 2,361 studies to screen, and we ended up identifying which were eligible and which were not, and excluding those that were not part of the scope to have a final number that you could see at the bottom left, which is 140 studies that were included in this specific review. So of these 140 studies, we have very heterogeneous possible resources here. 57 of them came from the scientific databases, and 83 came from organizational portals or great literature. 25 of them were screening tools, 44 were toolkits and guidance, and 47 of them were implementation strategies that I'm going to summarize briefly later. Most of this evidence comes from the United States. Also, UK, Switzerland, Spain, Canada, Denmark, Brazil, and Ireland are providing some information, but as you could see, the vast majority come from the US. Thematic focus were 92 of these papers were, or these resources were focused on human trafficking in general, 41 focused on sexual trafficking, and 7 on both sexual and labor trafficking. A couple of a brief description of the studies. We have 47 primary studies, 9 systematic reviews, 5 scoping reviews, 2 integrative reviews, and we have 55 tools or guidelines or evaluation of them. 52 of the studies resources focus on minors, 7 on adults, and 81 were focused on either a group of population or on both adults and children. So let's start with the tools. We found 25 screening tools. Of these tools, 17 of them were focused on human trafficking in general. 8 of them were exclusive for sex trafficking, so identify sex trafficking. The setting was very clear in 15 of them who were focused on healthcare settings, 8 of them for multiple contexts, and 2 of them were not clear about in which settings should be used. Populations are mostly, as I mentioned, for general population, 13 of these tools, 8 were exclusive for identifying minors, and 4 tools of them were specifically designed for adults. And very important to mention here that we also identify which of these specific tools were had some kind of validation process to show that the tool was valid. 10 of the studies were about the validation. It's not only about creating the tool, but also telling the readers what potential tools were validated for all the potential process. 3 of them were went through a formal validation process, and 7 of them didn't have the full validation process, but had some kind of assessment of the diagnostic properties of the tool. So the general idea of the tools here for you important is that most tools focus on general sex or trafficking. None of them specifically address labor organ trafficking. Tools for minors usually are focusing on commercial and sexual exploitation. Most of the tools are questionnaires, checklists, or interview guides. And these tools ranged from 4 items, the shortest, to 100 items, which is, of course, a very long tool. Most tools do not require special training. They are relatively easy to apply according to the readers, to the author, sorry. And few tools have been formally validated. And this is important when we are talking about tools because there are many tools and users may want to know which might be the best one. Even though we don't have evidence about what would be the best, based on the validation and based on the evidence that we found from the studies, we wanted to highlight these specific 6 tools that you could see in this specific table. The first 3 tools that we could see in green here, which are called the CSEIT tool, the RAF tool, and the TVIT, which is the Vera Institute tool. The 3 tools might be popular among people that work in the field. They might be the ones who have gone through the most comprehensive validation process, and we think we wanted to highlight it. The first one, the CSIT, is specifically for sex trafficking, focused on children and adolescents, and it could be applied in multiple settings. But the problem of this tool is that it has 48 items, which makes it really a long tool. Also for screening tool, we would like tools that are a little bit shorter. There is some information about how to access. The RAF tool is a very popular tool, which has been validated, and also a very short tool, which makes it very attractive for use. And it's focused on human trafficking in general. And the third one, the TVIT, is focused on human trafficking in general. It has been extensively validated. It's a really good tool, but it has 2 versions, the long and the short, 31 and 16 questions respectively, but has been the one that has had more studies on validation. Deserves a special recognition, the 4th one that you could see there, which is also called the Greenbound tool, but that is a very short tool of 6 items that has been focused on sex trafficking in children and adolescents, and has a lot of studies, mostly from the same group that developed it, but it's a tool that has some process of validation. It hasn't gone through all the potential validation steps that we should follow, but it's a short tool and has some experience in the field. The last two tools haven't gone through the full validation process, but has some performance accuracy measure that makes them attractive, but may require more research to validate them. And they are 14 and 11 items each. So those are the ones that we wanted to highlight after we went through all of them. Additional information that we found and we're going to put together in the final report and the final publication of this work is that we have also some toolkits and guidance that provided from different resources. Of these 44 toolkits that we found, 31 cover human trafficking in general, 10 focus only on sexual trafficking, and 3 of them cover sex and labor trafficking. The setting, most of them are for general healthcare settings, 12 of them are for non-healthcare settings, and 5 of them were not specifically setting specified. 27 of them for all age groups, 15 for children and adolescents, and 2 specifically for adults. As I mentioned, most of these studies come from the US. The most important idea from this specific toolkit is that most resources prioritize practical guidelines, including trauma-informed care, red flags, interview protocols, and referral pathways. Several include reference and screening tools, some of them the one that I have mentioned in the previous slides, and children and adolescents are a frequent focus, particularly, as I mentioned, for identifying sexual exploitation. And most of them emphasize there should be a clear interagency collaboration, victim-centered care, confidentiality, and training of the provider to identify this case. Very few of these toolkits explicitly mention labor trafficking or organ trafficking. That is a gap that we identify. We also found 34 resources on indicators of human trafficking. Some of them were from toolkits, reviews, reports, and primary studies. The most common signs, as you could see in the box in the middle, physical signs are usually referred about specific signs on malnutrition, hair loss, branding tattoos that have been associated with human trafficking. Some behavioral signs are fear, distrust, uncooperative behavior, and some health issues that we are all aware is STIs, pregnancy, and mental health disorders. Age-specific trends on indicators, as you may imagine, for children and adolescents, physical abuse, anxiety, depression, while in adults, most of the cases are more related to reproductive healthcare issues and documented status and fear of authorities. There is no standardized classification of human trafficking indicators, which makes it more difficult to identify what would be the best of them. Indicators are very clear to emphasize this. Indicators are not diagnostic tools. It's just some indicators to consider, but they need to be considered, but they are not diagnostic tools. Human trafficking victims frequently present overlapping physical and psychological and environmental indicators, like the one that I just mentioned. And it's also important to highlight that the studies also mention that beyond physical and mental signs, contextual factors like lack of document and stable housing, controlling inappropriate companions, are critical to identify trafficking situations. Lastly, implementation strategies. There are many of them in the literature, 47 documents, some educational intervention on how to train healthcare workers on identifying human traffic victims. 23 of the strategies that were identified in the studies are usually webinars, modules, expert-led presentation, case studies to train people about this identification. Implementation tools and protocols. There are some studies about screening tools like PERR, RAFs, and the AI-based Octavia software that had improved human traffic detection when paired with trauma-informed training and workflow integration. These tools might be useful to implement this in the healthcare settings. And you might also be aware of a couple of experiences with the use of ICD-10 codes for a study focused on evaluation of how these codes have been used in the clinical charts to identify patient demography, comorbidities, reason for visits, among others. Finally, analysis of practices. 14 studies focus on provider perceptions, tools used, barriers to detection, survivor-informed strategies to improve identification and support. The important thing for this specific implementation strategy is that we don't have clear evidence that the use of these tools are going to increase the identification of victims. That's the hope, that these tools are going to increase the identification, but we are lacking of evidence that has compared the use of tool without the use of tools to identify this. So I think there is more research on that we need to raise awareness, and barriers like time of constraints and unclear next step after the identification are also very common in the studies. And the ICD-10 codes for human trafficking are rarely and inconsistently used. That's also a key finding from the studies. And some studies recommend mandatory training, EHR integration, and standardized protocols. And human detection in healthcare remain consistent, and that shouldn't be surprising to some of you. Trauma-informed training, clear guidelines, and multidisciplinary approaches are recommended to improve identification and survivor support. To finalize, the main conclusion of all this evidence, I know that there is a lot of information here, is that the multiplicity of approaches across resources, along with inconsistent definition, trauma categories, and indicator classification, limits coherence and human trafficking detection efforts and underscores the need for greater conceptual and methodological alignment. Also, the absence of a very clear reference standard on human traffic detection limits validation efforts, resulting in very few tools that have been validated. As I mentioned, there were 25 tools, but only 6 of them might be highlighted, and 4 of them have been really gone through a more structured validation process. So that reduced the confidence in the rest of the tools and their accuracy and their utility in real life. Most tools and guidelines address trafficking in general, as I mentioned, but some of them, mostly those that are focused on children and adolescents, emphasize sexual exploitation. Other forms like organ trafficking, forced begging, and survival marriage are rarely included, as I mentioned before. And while continuous training improves provider awareness and confidence, its impact is limited by systemic barriers that we also know, such as time constraint, lack of privacy, provider discomfort, and this must be reinforced through institutional protocols and interdisciplinary collaboration. Validated tools, evidence-based clinical guidelines, and coordinated multi-sectoral responses are essential to strengthen the human traffic detection and ensure trauma-informed survivor-centered care. Future efforts should prioritize decision support tools and implementation research on the impact of these tools in the real life to enhance real-world applicability, minimize duplication, and promote effective and compassionate responses across sectors. So I'm going to stop there. There is a lot of information to digest, and I will leave it now to Andrea and Esther to discuss a little bit about our findings and perhaps next steps. Thank you.
Thank you so much, Ivan and Danielle, for that review of the findings there. Yeah, we'll invite Esther and Andrea to, starting with Esther, if you want to share your screen there. They're going to talk about more of the origin and motivation behind the project, their experience participating in the development of the evidence synthesis, some key reflections on the findings and challenges in addressing human trafficking in healthcare settings, and some suggestions for next steps there.
Okay, good afternoon, everyone, and thank you for joining us. My name is Esther. I'm a regular Canadian, a mom of 2 wonderful children, and I work at the University of Lethbridge, but this research is not related with my role here at the university. While I do not have a lived experience of human trafficking, it's a very particularly insidious problem, which makes it very challenging for affected individuals to come forward, or mostly silenced because of the fear and the stigma associated with it. So my interest and commitment to this topic began in 2020 when I started attending trafficking awareness session. I think I went to ACT a few times too, and listening to stories of survivors and frontline workers within community initiatives. As I listen to these real life experiences, I will go back and just review the literature to understand the scope of the problem. One thing that stood out to me particularly was the urgent need to explore more opportunities for identification so that timely intervention can be provided. I would usually just see police reported, incidents or, statistics. So that was something that stood out to me. As I continue to engage in this way, I had some research ideas and I connected with the Alberta Sports Support Unit to explore them, to refine them, as a citizen and identify helpful resources or partnerships to move the idea forward. The Sport Support Unit offers expertise, training, and resources for research initiated by patients, citizens, or individuals who have lived experience on specific topics. After many interactions with them, I had a draft proposal that I could use to sort of get the interest of potential PIs, investigators, or funders on the project. In 2023, we actually secured funding from the Sport Evidence Alliance, and subsequently, Andrea joined us, bringing a valuable frontline experience from the Action Coalition on Human Trafficking Alberta, also known as ACT. Our research team further engaged with the ACT team to ensure that the research findings reach the appropriate audience who needs to be informed, that is you. Thank you for attending today. This journey reflects the importance of community engagement and persistence in building meaningful research for Canadians. So why am I pursuing this, or why is this important to me? I think human trafficking, as everyone will know, is a serious violation of human rights and a very severe manifestation of violence and exploitation. What was particularly shocking and heartbreaking to me was the age-related statistics that's associated with trafficking. It has very devastating effects on health and well-being, according to the literature and according to reports from survivors, parents of survivors. You will hear them and you will know that this is very devastating. Yet, over half of those who are being trafficked are not identified when they access the health care. So for me, and from the literature, very well much the American literature, it's a critical opportunity for healthcare professionals to intervene and provide timely support. However, I observed the lack of Canadian literature around this topic. So that's why I thought it was a good thing to bring forward. And who needs to be thinking about this? According to this review by WHO, trafficked individuals often access emergency rooms while being trafficked. After leaving, they may use other wide ranges of services like dental, reproductive, maternity, mental health. And this underscores again the need for training across all specialties, not just emergency care. So here I put further directions. Of course, that's why we're here to talk about this. But before saying that, I just wanted to highlight that this work aligns with key activities under Canada's national strategy to combat human trafficking. I have listed just two important aspects that I think it covers. It addresses the need for developing multi-sectoral trauma-informed training tools. And more broadly, I think this research facilitates or is creating a pathway for enhanced data collection, which is essential for understanding the prevalence and incidence of human trafficking. Without accurate data, it will be challenging to design effective policies, allocate resources where it's most needed. However, establishing further directions will require engagement with stakeholders who will define research priorities going forward, I believe, within the Canadian healthcare context. I hope this session will serve as a recruitment opportunity or platform for interested stakeholders and provide a segue into priority setting discussions, ultimately leading to more meaningful research and action. So I'm very grateful to the Sport Evidence Alliance for this very important support to fund this research. Sport Evidence Alliance is co-funded by the Canadian Institute of Health Research, and this research will not have been possible without the interest and dedication of Dr. Flores' research team. I did a lot of cold calling initially, so this is very important to mention here that their interest was very key to this. I would also like to extend my special thanks to Andrea for jumping on the project with us. She brought a lot of frontline experience that provided us with valuable insight that grounded this research in real-world needs and context. The support from ACT has been essential in mobilizing knowledge gained from the scoping review to reach the appropriate audience. So thank you so much for your interest and joining us today. I look forward to our discussions. Thank you.
Thank you so much, Esther. We're going to pass it off to Andrea now to provide her insights.
Thank you so much. And I have just some brief comments. I don't have a PowerPoint to slide. I just wanted to share some of my reflections over the course of working on this project. As Esther mentioned in her slide, that I was a citizen partner on this project. My name is Andrea Burkhart, and I started working on human trafficking issues in 2008 and co-founded ACT Alberta in 2011. I had some years as executive director there, some years on the board of directors, but I don't work for ACT Alberta now, and I'm not on the board of directors now. So in my time since, I've worked on other intersectoral systems change, public health issues, and have finished a master's of public health. I now work in a Canadian health system, but I'm not in this project in either of those contexts. I'm just here as an interested citizen. So not representing the healthcare system I work for and not ACT Alberta. So as Esther mentioned, she approached me last year and asked if I wanted to participate in this project. My work has primarily been in an advisory role, and this team has been exceedingly patient and very gracious as I've challenged us a number of times to think critically about the definitions we're using, considering the full breadth of human trafficking. And also we've had some really thoughtful discussions on engaging people with lived experience of trafficking in a meaningful way. On that last note around engaging people with lived experience of trafficking, we've talked a lot about the timing and some other factors that one would need. Esther talked a little bit about setting research agendas for future work, and I think maybe it's happening too slowly, but I think a lot of work in research and community-based responses and policy is slowly acknowledging how important it is to have the voices of people who've experienced the issues really informing those agendas. But we all know what it's like to be brought onto a project midstream when maybe wheels are in motion, decisions have already been made, et cetera. And I think that risk exists in any collaboration, but the risk is really profound when we're engaging people with lived experience. So we've had discussions in our team about power imbalances, factors like trauma-informed perspectives, which have been brought up, but also strength-based perspectives, considerations related to anti-oppression frameworks, diversity, equity, and inclusion analyses, and some approaches that will help, I think, ground that engagement work to be meaningful. So it's something we grew our sensitivity to as a team in the last year or so. The other aspect of this work that I think this team has been really thoughtful in digging deeper into, and Yvonne touched on it, and that is with regard to the definition on trafficking, or definitions, plural. And we've seen how, and I think how it's been problematized in an important way, that when we see the word human trafficking, we need to dig a little bit deeper into what does that mean. We've seen, conflation of human trafficking with other issues. Those of us who have worked or are working in this field, I think, have that firsthand experience of that challenge. And this is in part why assessment tools are so critical, but also in part why this work has been challenging because of that conflation with other issues. So we didn't really dig into it, but the international frameworks on human trafficking exist. The Palermo Protocol was first developed a quarter of a century ago, which makes me feel really old. But I'm very intentional about thinking about the Palermo Protocol as a framework. It's not a definition per se, and it has very limited guidance about how one actually implements it. And I think Yvonne spoke to that in the challenges in the research that's come up when it comes to interpretation of that framework. And that's the very essence of assessment tools and diagnostic tools. I think in the past, other problems we've seen around human trafficking that this group also touched on, and we're really conscious of, the politicization of the topic, certainly something that's been experienced internationally and in Canada, and also the sensationalization of the topic. So many of us came to work on this topic because we read a book or saw a film, and often those public media resources present a very sensationalized perspective on trafficking. So, like Liam Neeson films like Taken, for example, raised a lot of awareness on trafficking, but that's not always the reality of how trafficking presents, often more nuanced. So I think, recognizing how the larger ecosystem we're all in impacts not just this project and our work here on the scoping review, but also other work on policy and, programmatic responses. But definitely something we saw in our findings as well. I think we cannot resolve the human trafficking definition issues in this project, when probably not in this webinar either. But it was raised as a topic throughout our project that we were able to really thoughtfully walk through. I think Yvonne also touched on the dearth of resources on labor trafficking and organ trafficking. I was not surprised to see that, but I was disheartened. I think, from my experience working on this issue, we can collectively put our heads in the sand and say something like organ trafficking couldn't exist, but we used to say that about domestic violence too, and we were abundantly wrong about it. I had really hoped that there would be a healthcare related resource on organ trafficking specifically, because if there's an audience that's most relevant for such a thing, it would be healthcare workers and frontline clinicians. So there are some really notable gaps. But I think as a team, we tried to puzzle through some of the big things, tried to make some meaningful progress. And really, I just can't thank this team enough for taking the time and the patience to really dig deep into the complexity of the topic. So that's all I want to share from my perspectives, and happy to hand it back.
Thank you so much, Andrea, for your insights there and contributions. It sounds like you are doing some very meaningful and powerful work there that helped contribute to this project. I'm going to open it up now to invite the participants here to share any questions or comments you have in the chat. While you are thinking of some of those questions, we'll kick it off with answering some questions that were submitted earlier ahead of time for the UNED team. But yeah, just feel free to throw any questions you have in the chat there, and then we'll go through and review them shortly. I'm just going to get my screen back up here as well. Okay, so these questions are directed to anybody on the UNED team who does want to answer there. So this starting off, we have which tools identified in the scoping review have undergone formal validation processes, and what were the most common limitations in those validation efforts?
Maybe, do you think that I should show again maybe the slides? I'm going to go back to this because I know that it was very rapid that I show. Let me share the screen one more time here. And I think that it's really important to, okay, what about now? Are you able to see? Okay, I can talk well now. So there were, say, 6 tools that we identify out of the 25 that could be considered or highlighted because they went through the validation process. Are you able to see now? Okay, so these are the 6 tools that had not only, so there is a specific articles that provide all the information, how they were created, but also they went through validation. And validation requires some specific step that we follow to say that the tool is valid. And why we need to do that? Because there may be a certain list of items that we think might be good to identify a specific feature, in this case, the potential of having human trafficking, and all these specific methodological process that we follow or that the author follow to validate needs to go through different steps to get to the final conclusion whether the tool is valid or not. And what is valid is a tool that is easy to understand, is clear, and is measuring what it should be measuring. Because some items might sound like they are obvious and they might be related to human trafficking, but the whole tool in general need to provide evidence that they are measuring exactly that, and they are not identifying other kind of things. And validation process follow a very strict protocol, methodologically speaking, that requires a statistical approach to identify what are the best items, if the items are not overlapping, if the items are measuring different things or the same things, to came into the final tool. And all this process have been only conducted for this specific tool, mostly for the first four that are in green here, the CSEIT, the RAFT, and the TVIT, also Vera Institute is the other name, and the green bound. The last two are tools that have been some kind of performance measure, like for instance, sensitivity and specificity, but they haven't gone through all the validation process that we would like from a methodological point of view. So we wanted to highlight the first four, the ones that are in green, which are the ones that have gone through all this process. And we think from a methodological perspective that they are the best tool and the tool that are measuring what they should be measuring, and that we should put more effort because they should be the more trustworthy ones. The problem of the number of items, that's another discussion, because we could have a very valid tool like the first one, the CSIT, but from the implementation perspective, for identifying sex trafficking victims, children and adolescents, it's a really good tool, but it has 48 items. And the applicability of a tool that has 48 items, of course, is very difficult. There are a lot of barriers. There is time constraint that we know in an emergency room that may make that tool not applicable in some context because of the length. But also at the same time, we also want a tool that is short and it's valid, but also that is applicable and extensive. So we would like to prioritize these tools to highlight from our review.
Can I jump in with
with
complementary note?
Sure.
Just to mention that very few of these validation studies included diverse geographic or cultural groups, right? So that makes the cross-cultural applicability of these tools very challenging. Most tools have not gone a longitudinal assessment, making it difficult to assess their long-term utility and performance in practice. So there are some limitations, even though these are the most recommended tools because they have gone through a validation process. There are also some limitations to the validation studies. And I think for us being in Colombia, in another country different than Canada and the US, the most challenging one is that they have not been validated in a context like the one that we are right now.
Thank you both for sharing that. Yeah, I think it's important like to note that one tool doesn't fit all the areas and demographics that we have in different areas. There's like the clinical realities in an emergency room, for example, are going to be really different from those in a rural clinic or a pediatric setting. So having guidance on some of those matching tools to the context is really important. Another question that we have here, and you did touch on this already a little bit, but if we can just reiterate here, which forms of trafficking are most frequently addressed in the existing tools and which are underrepresented?
Yeah, I think I touched a little bit on that, but as you could see, human trafficking in general, and of human trafficking in general, you could see in the second and third tool that are here, and also sex trafficking, mostly in children and adolescents. There is significant literature on sex trafficking, specifically on this population. That would be the second one. So human trafficking in general, sex trafficking, and as I also mentioned, the rest of the human trafficking the types were not fully addressed, and we also have a discussion about the organ trafficking, among others. So yeah, it's more about general and also sex trafficking in children and adolescents, the ones that are more represented in the literature.
Something that could be missing, Ivan, our labor trafficking is not as well as represented. Organ removal, as Andrea was mentioned, forced marriage, forced begging, or exploitation in criminal activities are those that are underrepresented in the tools that we found.
Thank you. Yeah, we see that a lot in the work that we're doing at ACT Alberta too, that there is a disproportional representation between tools and awareness in general, between labor trafficking and sex trafficking and some of the other forms of trafficking that we are seeing. So it's not surprising that it will show up in the research there, but it's important to highlight the disparities there for sure. Next, we have what should be the key priorities or next steps for healthcare systems, researchers, or policymakers to strengthen identification and response to trafficking?
That's a complex question. So I'm going to talk from our side, taking a look at the evidence first, and maybe Andrea and Esther may want to jump in and complement. But from the literature, we can find that just labor trafficking and the other trafficking types that Daniel just mentioned, I think research on those specific ones there's a gap in the literature. So not to say that we have enough evidence for sex trafficking and human trafficking in general, but the specific tools for a specific type of trafficking might be a matter of further research for researchers who are interested in this to create these tools. I would say that is something that was a clear gap. The other thing would be validation of the other tools, creating tools that are short and maybe validate them with more research that will facilitate the implementation. Also, some evidence on the implementation, and that means, let's say, for instance, taking these 2 or 3 tools and implementing them in a specific healthcare setting in which we could measure, for instance, a relatively easy approach would be to measure, okay, let's train people, let's use these tools, and let's measure what happened in the next 1 or 2 years to see if we are increasing or not the number of cases that are identified in comparison to the previous year. So that's implementation studies to measure the real impact might be something also a focus for further research. And that will create awareness if we have evidence that not only that the tools are good and valid, but also that they are increasing the cases and that's it. And the other thing, of course, is, as I mentioned, 95% of the literature comes from the US. I think more evidence from Canada is required as well to support decision maker in the country for decision making. I don't know if Andrea or Esther would like to comment on that.
I have some comments, and maybe not directly answering the question, but more to provoke us into thinking also when we put attention and resources into identifying people who've been trafficked, we must put as many or maybe more resources into solidifying a response to those individuals. And that's been a common problem working in this ecosystem has been awareness leading, hopefully, Yvonne, as you say, leading to more people being identified, but then the response must be adequately funded so that those folks have access to what they need. Because the last thing anybody wants to do is to let a person down who has overcome all the barriers to being identified, and there are so many. So that's just my plug for the other side of things. I know that's out of scope for our team and for our project, but something for us to all think about.
Yeah. So thank you for the answer. I just also wanted to add that, engaging survivors and frontline providers in that tool development, and I know that's why we're here talking about this. I think it's very important to make sure that the tools fit into the different population that will be encountered. I think it's already been touched on, but as we talk about next steps, I think those are the places to start looking at who should be engaged, who should be talked to, who should be part of the next conversations. So yeah, thank you.
Absolutely. Thank you. Thank you, everybody there. I'm going to go to the chat here and answer some questions that we have. One individual is asking if we can speak to discrepancies between how Canadian law defines human trafficking compared to the Palermo Protocol and how that affects the ability to respond to human trafficking. And I know, Andrea, you did touch on that a bit if you want to help answer that one, or if anybody else on the team wants to jump in.
Well, I was actually just typing a little chat back to that question, so I don't mind speaking to it. But of course, the law enforcement response was outside the scope of this project. We were looking just at healthcare and clinical responses. But my quick answer to that would be that a lot can happen outside of law enforcement, a law enforcement validation that somebody has been trafficked. There are discrepancies between all law enforcement perspectives and Palermo Protocol, because Palermo is a framework, it's a foundation, it's really not a definition. But I would just say, in short, there's a lot that can be done to identify and assist people without the official law enforcement stamp that someone's been trafficked. I don't know if anyone else wants to say more about that.
I think that was a good overview of it there, Andrea. And we do have a few other questions here, not a lot of time, so I'll move on to the next one we have. We have a question here. It says, you briefly touched on possible future research directions, but they're curious as to any specific topics you'd like to address or pursue next. And they'd like to thank you for doing this incredible work.
I don't know. I think I touched on that. I think it's about, maybe I'm not completely understanding the question, but it would be focused on specific tools to identify all kind of human trafficking. First, second, implementation, the real impact. And third would be more Canadian study. I think those three from the evidence review. Of course, Andrea has also mentioned, okay, what is going to happen if we identify and people don't know what to do next? And also some research on barriers in the Canadian context might be also something to focus on, because if we are able to identify those barriers among the healthcare workers, for instance, we might be able to address them or to focus the efforts on addressing those barriers, because maybe what is happening is that people know about the tools, but they don't want to, or they don't know how to use them, because they don't know what to do after they identify a potential case. So I think barriers and identification of how is the context in that case, and awareness that among healthcare workers might be another further step to consider. Daniel, Andrea, or Esther, if you want to add on that, that would be great.
Just one thing, Ivan. What do you think about conducting clinical practice guidelines about this topic? Because we didn't find any clinical practice guidelines with clear recommendations on this topic. I know it might be very difficult to tackle, but well, that could be something to explore too.
As guidelines, one of my areas of focus in my research work, and guidelines are usually the way the healthcare workers follow and do recommendations in their real life on a daily basis. So we usually do guidelines for specific diseases most of the time. So it's very difficult unless there is a specific disease in which we think that there is a strong link or there is a high prevalence of human trafficking in this disease. I don't know, maybe STI, sexual transmitted infection diseases, might be as part of the usual STI guidelines to raise awareness among the group that are doing guidelines, to put some kind of questions related to human trafficking, to use this tool, for instance, a patient that has this specific diagnostic, for instance, or among other diseases. So we might need to do some research about how to include this, but rather than focusing on or doing guidelines in general that would be spread about emergency department doctors about how to provide recommendations and how to include these tools in the regular clinical decision that they make. There is a challenge there, but yeah, for sure, it's a matter of further research.
Wonderful, thank you. I'm going to sneak in one last question here. Do any of the tools you've researched here transfer well to other languages using something like Google Translate if you're trying to translate the tools?
We didn't find anything about the translation. Most of them were tools that were in English, but we can expect that it should be applicable. The problem with translation is what Daniel was mentioning before. there are a lot of contextual things in a different country, in a different setting, in which the full translation is not enough. That's why we do the validation process also includes language, because the way it is framed in English and the full translation maybe means a different, comes to a different idea in another language like Spanish, French, Chinese, among others. So that's another of course, area of further research is the validation of these tools to specific different languages to see that they don't lose what they really want to identify in these specific questions. Yeah, but we didn't find specific evidence about translations.
Okay, thank you. And thank you all for participating in some of your thoughtful questions. I know we didn't have time to answer everybody's questions today, but if you do have any other questions that you have, I'll put our contact information up on the next slide here as we close. Here's just ACT Alberta contact information if you do want to get in touch with ACT Alberta, our victim services team, or education here. There are some questions about whether these when this information is going to be released, and we will be helping distribute that information through ACT Alberta on our website here, and just getting that information out to everybody once it is released to the public there. I also wanted to highlight that we have just taking this opportunity to highlight that ACT has officially released 2 national resource toolkits today for frontline professionals responding to human trafficking. So the first is a frontline workers, a toolkit for frontline workers supporting adult survivors of labor trafficking and forced labor, which is the first of its kind in Canada. And the second is a toolkit for frontline workers supporting adult survivors of sex trafficking. So both of those toolkits are available on our website for free, and we do encourage you to share them with anybody who may need these resources. I'd like to thank everybody from the UNED team today for joining and helping share this information and this important dialogue, and thank everybody who joined today to participate. We will be sending out a link to this webinar for everybody to view after as well. Thank you, everybody. I'd like to conclude there, but if you have any last-minute remarks, you're welcome to share. Otherwise, that's it for our webinar. That's all the time we have today.
Thank you so much.
Thanks,
Thank
everybody.
you.
Thank you.
Bye.